everyone, and welcome to the American College of Healthcare Architects Master Series 2.0. We have the privilege today to speak with several amazing healthcare architects about the topic of caregiver wellness and staff satisfaction. My name is Daniel Perschbacher, and I'm a principal in the healthcare practice of HMC Architects in San Diego, California. And I'll be moderating the panel today along with my co-host, Angela Mazzi.
Thanks, Daniel. My name is Angela Mazzi. I'm a past president of ACHA and a partner at GBBN Architects.
And now that you've met us, let's meet our panelists.
Lee Health, located in Southwest Florida coastal area, is comprised of 4 hospitals and 2 specialty hospitals with 1,744 patient beds, a regional cancer center, over 950 primary and specialty care physician practice locations, as well as 7 outpatient centers. As the System Director of Planning and Design for Lee Health, Kent Lay's responsibilities are the coordination of architectural and engineering healthcare design consultants and the administration of master planning, programming, and space planning for all design and renovation projects for the system's acute care, outpatient, and corporate facilities. Kent oversees 14 in-house design professionals comprised of architects and interior designers who set design standards for use within each of the varied facility types. Kent also directs the Safety Risk Committee for the identification and assessment of all potential risks for each design and renovation project. Since 2019, Kent has served as a member of the ACHA exam committee. Julie Mullen brings over 30 years of experience in the healthcare design field and has led numerous projects from programming and planning through delivery. Julie's healthcare portfolio includes a wide range of healthcare facilities from new hospital design and construction to expansions and renovations in medical office buildings and ambulatory surgery centers. With a broad range of experience, Julie leads Gresham Smith's healthcare studio in Charlotte. She is committed to maintaining strong client relationships and delivering flexible, resilient design solutions that address the continuum of care necessary for positive patient outcomes. Jim Albert serves as market sector leader of the Hord, Coplan, Macht healthcare team, providing vision and oversight for a wide range of healthcare projects. As a lean trained professional, Jim is committed to helping clients imagine a better way of delivering healthcare services. He believes that a well-designed healthcare facility can improve the patient, family, and staff experience while making the workflow more efficient and effective. Jim's work focuses on designing complex projects within the hospital and ambulatory settings. He has spoken and written nationally on the importance and impact of effective healthcare design. Why don't we go ahead and get started with you, Kent? This topic of caregiver wellness and staff satisfaction, I'm curious from you, from the owner's perspective, why are we talking about this topic in the first places? What are some of the challenges and opportunities that healthcare organizations are facing today?
It's a situation that I see all the time. It was something that we saw brought to the forefront with the pandemic. So it was all in all the social media and news outlets, and it was really brought to the forefront to everybody. What our hospital caregivers go through and what they have to experience on a daily basis. The pandemic just made it to an extreme. But what everyone doesn't realize, and something I see all the time, is that it hasn't gone away. They're still having to deal with the same issues, the same stress, the same levels of anxiety that they've always had to deal with. And they just don't have those extremes that they have. So it's something that needs to be talked about and something that needs to be brought up. So we see it in a lot of different areas. We see it in retention of staff. When you see news reports of hospitals having issues with retaining staff, and I see that all the time when I have to talk to directors of departments and there's somebody new coming in. And even more important than that is recruitment, is how you recruit new people to come to your facility. I mean, you really don't have anything new that you're offering. You're just offering the position. You're not really addressing it. And we started working on some of this years ago when we started talking about lean, when we started talking about process. We started talking to users a lot more about how many steps do you take and where are your supplies and how can we make your job easier. And we've been finding out that's only half the conversation. And we really need to be talking about the other half of the conversation and talking about the person themselves. And I see that a lot in all the different departments that I go to, that we need to be addressing both parts of that, not just the process, but the person as well. And so as architects, I'm kind of excited that we get to address this just like we were addressing the process part. And we get to be a part of making more people aware, making hospital administrators aware that you really need to value those employees, and you really need to put an emphasis on employee satisfaction, or else you're going to continue to have the same retention problems and the same recruitment problems that you've been having all along.
You know, I would add on to that. You mentioned the pandemic brought a lot of this to light. Caregivers are really suffering right now, right? And it's, as there are staff shortages, it gets harder and harder on those that work in the organizations. And not just what they do within the organization, but how they as people feel. Rates of substance abuse, mental health issues, even suicides are really up among caregivers right now since the start of the pandemic. And there's just a tremendous amount of pressure, and it's this constant thing that is bubbling below the surface, and it's not always seen, but it really needs to be recognized.
I see that a lot where I get requests because they are trying to address the emotional, physical, the mental, spiritual side even of how they work and how they're able to support their patients and support the patients' families. And so you have to look at all of those different aspects and not just the space that you're providing them to work in.
The space has to be just one part of a very holistic approach by the organization, right?
Absolutely.
So Julie, we know there's this I'm fine culture in healthcare, and I think Ken and Jim have already started to flesh this out, but how do you see that changing as you're working with your clients? What different things do you see them trying to implement to really focus on the caregiver and make it okay for them to acknowledge that they have these additional needs?
Right. Well, in a lot of our projects, of course, you know, the go-to these days is respite rooms. And so we've started providing and talking about different kinds of respite rooms, whether they're spiritual, workout rooms, lounges, multisensory staff-only rooms, all of those sort of renditions. And I think that this is an oversimplification of what our caregivers need. I was just speaking with one of our researchers about a project that they've been working through with some staff. And, you know, the culture of administration actually allowing the caregivers to feel that they are able to take a break, I mean, a real break off the floor in an area that is not close to their patient, especially high acuity caregivers like ICU nurses who won't leave the floor because they don't trust their partner to cover for them because of the high turnover rate and the inability for them to become partners with their fellow caregivers. So I think the big change needs to be culturally. I think it needs to be with the administration actually insisting that their staff take breaks and monitoring it through key card access and other things that would allow them to understand that so-and-so has taken their 30 minutes and has had a real break from the floor. The other part of this that I think is the gorilla in the room is the hours that they work. The 12-hour shift. Now, I had a sister that stopped working 25 years ago. She never worked a 12-hour shift. She was a nurse, of course. She never worked a 12-hour shift in her 20 years. And now, if you're on a floor, you're working a 12-hour shift. 3 12s will give you your full-time status so that you can be a full-time staff member. And if you watch those people at the end of that 12-hour shift, they're completely not able to provide the care that they need to be providing. So we've talked about overlap. Do we overlap? But that sort of defeats the purpose of the 12 and 12 to cover 24. Even if you have a half an hour overlap, when you're doing your report out, it's not enough time, especially if you have 12 hours worth of notes to go through. So those are the issues that I see that we as design professionals, when we're sitting in user group meetings with administration present, with presidents of hospitals and chief operating officers, we need to bring that up. We need to talk about it. It's probably not a real popular subject, and we're probably not the folks they want to hear it from, but you know, some of us have been working in this field for a long time, and it's important that we give them our experience with how care has changed over the years.
You know, Jim, to piggyback on what Julie's saying, you know, she mentioned that the respite room is too simple, right? And one of the things that you said is that space is just one part of a holistic solution by an organization to really focus on the person of the caregiver, not just the role that they're playing. So thinking about, though, buildings and spaces and amenities, what are some of those spaces and amenities, maybe outside of the traditional spaces that we think of, like respite rooms, that when you're sitting across the table with somebody like Kent and the project, and you're starting to talk about how do we retain staff, how do we attract staff to come here? What are some of the space types and ideas and amenities that you're talking about with them?
One of the basic things that we start with, obviously the break room and the respite room are really important, but getting them with access to daylight is such a different experience. And I think that is a priority, and getting space close to them, because Julie, I love how you talk about making sure that we enforce breaks of leaving a unit, but a lot of that culture isn't there. So making sure the space is on the unit is really valuable, and balancing that with centralized greater amenities like rooftop gardens, meditation spaces, those kinds of spaces. One of the things that I've heard a lot of need for is access to healthy food 24/7. So that a lot of cafeterias close down, and the night shift or late shifts on the weekends, they don't have access to food that's healthy and nutritious and helps keep the staff going. And it sounds like a simple solution, but it isn't. So it's an important thing to fight for.
I think that's a great point with the dietary scenarios, because so many nurses are overweight. And one of the reasons is that they're working that 12-hour shift, which is disruptive to their circadian rhythms. They don't sleep as much as they need to sleep. They eat at odd hours. They eat whatever is in the break room. So I think your point is very well taken.
The types of spaces, getting those actually into the hospital becomes a financial decision. And many times the finances and the restriction on square footage, especially with the escalation of budgets these days, these are the spaces that get taken out first. And when we were talking about the fact that we need to have this from the top down. If it is from the top down, and it is with all of our senior administrators down to the directors and senior system directors, if that is from the top down, then it does not get cut out of your program, and it stays despite the fact that there are financial restrictions. That's one of the struggles that we have here. And then one of the other places or comments I get is offering concierge services, things to take care of your dry cleaning or any other type of concierge services that might help you out while you're at work and you can't do things, especially if you're working a 12-hour day. And I keep thinking about that 12-hour day that she was talking about, and at the end of an 8-hour day, I'm exhausted. I can't imagine 12.
Not just 12, but 12 on your feet, moving the whole time and interacting with people the whole time. It's a long shift.
Right.
Yeah, and I think it really speaks to this idea of having to be on versus being in those backstage areas, which can be so important. And to circle back to what we were exploring with Julie around culture change, it's hard to miss or value what you never had. So when we have a culture that doesn't prioritize self-care, that doesn't provide the offstage, and we try to introduce these other amenities, like Ken was saying, they're the first things that get taken out. So this top-down prioritization is one way, but there's some other strategies that you use to work these spaces in a way that will ensure that they stay in and that they get use, even if it's maybe an off-label kind of use?
Sure, I think one of the things that we really need to start seriously thinking about is making the business case for these amenities. And the only way you can do that is through documentation and through a clear study of retainage, post and prior to when these amenities are inserted into their projects, whether they're amenities or whether they're, for instance, design strategies that allow less chaos on the unit, less noise, less light interference, less disruptions. We had a unit that we recently did where we circulated the patients and the visitors on the outside of an ICU unit and had a service corridor towards the middle in order to decrease that. That was $1 million more to do it that way. But what I think would be really important to do are studies that show them that the retention of their staff is made up within, the life cycle cost of 3 years, something like that. So we need to find people who can work with us and understand how to put together those studies to really improve the caregivers' environments from a business case.
I think that's a great point. It's not a direct cost, but it's an indirect cost, and it really even can impact patient outcomes. So that business case is important, and that way to remove the stigma from the need to take a break. And we found even having in a break room a counter where somebody can look out the window and their body language can convey, "Leave me alone," is kind of a sneaky way to get respite in a culture where maybe you don't want to look like you need to be alone. So I think it's great that you're exploring a lot of these strategies because it is a spectrum of needs. We were talking about different amenities. So are there other things that you all are seeing beyond the concierge, beyond break rooms and respite rooms that have been effective with your clients?
So one thing that we've really found is that security and safety, that the physical safety provides psychological safety. And so whether it's how parking and the walk in from parking is for the staff, and that sort of setting your mind as you come in and feeling like you're in a safe space, or really how you reinforce, like Julie was just talking about, the on-stage, off-stage nature, because just in the news in the past weeks, we've had multiple shootings at hospitals make the national news, and providing real physical safety for staff is very important for their psychological safety.
Now, I had a user group tell me last year that they have gone to just their first names on their badges, because if their last names are on their badges, they'll often get harassed on social media. So I mean, these are the sorts of things that we can't even imagine that happens to these people while they're working.
I just want to talk a little bit about that safety aspect. That's something I hear all the time. the safety aspect from the time you arrive in your car and getting into the building, keeping in mind some people arrive when it's dark out and they want to feel safe. And that's just as important as feeling safe enough to speak up when you're at work saying, I have to take a break, I need a break. I've just had a patient pass away, or I've had a very difficult time, I need a break. And you want them to feel valued enough to be able to speak up and feel that safety. So there's a lot of different ways to look at how safety comes into play.
What do you notice different units may require that create different kinds of respite needs, maybe based on acuity, maybe based on patient type, inpatient versus outpatient settings?
So
Patient types, and some of the ones that we forget about are the outpatients. We typically like to think about the ones that are foremost in our minds, the emergency department staff, the ICU staff. But you also need to think about a home health care nurse who's dealing with a patient with multiple comorbidities. I can't say the word. Comorbidities, I can't say it anyway. Because they're dealing with a patient that has a lot of needs. And it can be just as difficult as someone who's working in an emergency room and trying to figure out what's wrong with the patient. So it's too easy to only think about those in the acute care setting. But it really is a matter of remembering that the caregivers are there to support families, they're there to support loved ones, they're there to provide support to the patient. And they have to be able to refresh their mind, they have to be able to step back when they need to be able to do that. One of the things we're trying to avoid is clinical or medical errors, because at the end of a 12-hour shift or something like that, and especially when you're in a high pressure, high anxiety setting, such as, and I keep using the EDs and PCUs as the example, they need to be able to step back.
Really interesting, Kent. You mentioned the patients and their families, and I think that's obviously that's why we're all here in the healthcare business, is to ultimately have the work that we do trickle down to the patients and their families that are receiving care. So, Jim, I'm curious from your perspective, how can caregiver wellness impact those patient outcomes that we're all in the business to provide?
I think that's a great question, and it feels like an intuitive link to say that the people that the patients and families interact with and how they feel when they come to work every day, that calmness or that stress will translate directly to the patients and the families. And there's been a lot of research that shows that stress, that chronic stress that the caregivers are under, and really even PTSD, right, that carries through with downstream effects like medication errors, or even just snapping at patients or their family members, or not bringing what they need in a timely way. And that care that is given by the frontline worker is so much more impactful than the actual feel of the space on the patients and their families. And as architects, that's probably not a really popular thing to say, but how our space can take care of the caregivers is more important than how the space takes care of the family, right? Because the caregivers are the ones really interacting, and that'll leave a super lasting impression on the patients and their families.
And I think that goes back to, how do we make the business case for that? Whether it's culturally to reduce the hours or to overlap the hours, if that's the big problem, or as you said, we don't have the ability with space to solve every problem. But if we can impact that culture, we might be able to, again, put the studies in place for caregivers, administrators to understand what they are saving. So I think I keep coming back to that. We've got to give them proof. And the only proof that's going to work for them, as we all know right now, is financial proof.
What things have you done to kind of measure those strategies post-occupancy?
We do a lot of post-occupancy evaluations. I can't say that we've done anything that's related or correlated to dollars yet, but we have done a lot of studies that look at time and steps and time in lounges and so on and so forth. But I think the culture needs to be for the administrators to take that information, embed it into turnover rates, those sorts of pieces and parts that we would need logistics people to help us with, to really understand that the outcomes that they're getting, the better patient outcomes, the less staff turnover, that's really saving them the financial burden that turnover or bad patient outcomes bring to bear.
Kent, I'm curious, you're sitting on the owner side, you're part of the, the foundation of projects as you're scoping them out and looking at what a project can be. The idea of staff retention, training, recruitment, how much does it cost to actually bring on a new nurse and train that person in the way that you do business? And you all have to be talking about that, every single day. The value of your caregivers and your staff. So what do those conversations sound like on your end? How are you all, putting a price on the ability of the space and the staff amenities to, train and recruit new staff?
It's really becoming a trade-off. You have that financial side where the business part of it has not been proven yet. You have the leaders of our hospitals who, when I was talking to them about this subject, I had to almost interrupt them because they didn't want to stop talking to me about what they would like to do, things they would like to see in the hospital, and telling me just providing a room is not enough. Just providing a window is not enough. Their staff don't feel valued enough to be able to want to come to work every day and to enjoy the time that they're there and to do a little bit more than what the job description says that they're going to do. So as we're programming things, it becomes interesting where I always try to incorporate extra space or as you're laying space out to make sure you get windows where you wouldn't expect them, or you look at, again, going back to the process of where do the patients go? How do we follow them through this particular department or this particular clinic or whatever it is? And how do we make those spaces for them? At the same time, don't forget about the caregivers that are taking care of those patients. So there's a struggle between the business side of it, the financials, and looking at how much space we have to work with. And so I'm not always able to address those needs as much as I would like to. But I know from all of our hospital administrators that I've been talking to, they sure wish they could.
It's really interesting that you say that they sure wish they could, right? It's a limited set of resources, and how do you prioritize space for this versus space for that? And I think that if we want to see organizations really put a priority on caregiver wellness, there are some easy ways to measure the outcome. Did they succeed in that, right? If you're looking at a patient unit design and you filled every window with a patient room and the break room is on the inside of the unit and you couldn't take one patient room away or make the building one bay longer to make sure the break room got a window, that's a statement. That's a value that's baked into that plan. If the staff break room looks like an afterthought and the physician's lounge looks like a little palace, right? There's a value statement baked into that. And how we help our clients talk at the very beginning of the process about what are those guiding principles so that we bake them in at the beginning and make sure they're defensible throughout the process. I think that's exactly what you're trying to do if I understand it, Ken, is to make sure that those values get baked into the plan.
It goes back to what Julie was talking about. It has to start at the top. It has to come from the top down. And our system hasn't seen it yet, but it's gaining strength. And I see more and more conversation happening about it, which is a good thing, because then it is going to be coming from the top down. And to your point, yes, when you have in the larger projects, your visiting sessions, and you start describing what is most important to this project, what is it you want to see from this project, that's when it needs to be brought up, and it needs to be repeated and repeated so that it's not forgotten.
I think one of the things that we definitely can impact is operational efficiencies in our design, which again, you know, when we look at how people are doing their work, and we see from our experience that there's a better way of doing it, the onus is on us to bring that process forward and to actually talk to the caregivers, whether they're physicians in the room or nurses, it's usually nurse managers in the room, about that process and how to conduct change management once the new process is built, to be sure that they're using those facilities in the way that they were designed to optimize their process. And I think that's got to be a satisfier as well.
It's interesting, Julie. I was scratching a note on a question to ask, and you touched on it, but I was thinking of it from the opposite perspective a little bit. So much of what we do as healthcare architects, right? We're so into lean design and being efficient with design, and to play devil's advocate a little bit, some of that can sound like, how can we get more with less, right? We're talking about how stressed out the caregivers are, how hard they're working. They're already working 12 hours a day. And we say, well, how can we get the equivalency of 13 hours a day from the caregivers in 12 hours, right? So I'm curious, what are your thoughts on that when you're sitting in those user meetings, when you're talking to the administration on, you know, blending with the conversation of lean design and efficient operations, with, you know, bringing in some of that empathy on the people that are actually performing the steps that we're trying to.
Well, I think some of the things that we do, which is like design thinking, visioning sessions where you're actually talking about the process, and you hear these stories. Well, first we bring them in and they do this, and then we put them over there and we do this, and then we bring them back over here and we do this. And you're like, why are you doing that? Well, we don't have enough staff on this unit, so we have to do it that way in order for, and they've got all these reasons that are, you know, the reasons that they're doing it that way. So, you know, what we need to do is go back, step back and think, they've been doing this process forever. So how can we get them to do a process that's more efficient and make them think that they've actually originated it? Because that's how you get the buy-in, is to convince them that the process that might work better is one that they can actually get on board with.
I also think, Julie, as you're working with them, one of the core fundamental principles of lean is that you're not looking to eliminate waste and then shed people, right? But you're looking to let those same people do higher value things.
Exactly.
Right. And what caregivers really want to do is take care of people, right? They want to administer healthcare to patients. So all that wonderful work that you're doing to eliminate waste and steps and unnecessary processes is so that they can spend time with patients, making sure they get better, not to have less nurses or longer shifts,
Exactly.
right?
Exactly.
Yeah.
You know, when you ask folks if they enjoy their jobs, I think that's where you get to the place where you really understand what satisfaction is. You know, we all enjoy our jobs. I think we wouldn't be doing it for as long as we have. But when I ask some of my staff, you know, whose wife might be a nurse, your husband might be a nurse. Does your wife love her job? Oh no. You know, I hear that all the time. So I find that troubling.
I'm not hearing enough conversation from consultants that we use, asking those questions about, do you love your job? What can we do to help you love your job more? I'm hearing more of the lean process and all the typical things that we do, and not enough of tell me what I can do to help you. And I wish I heard more of that.
That is so important because we know, and we've a little bit touched on this, that when a caregiver is stressed out, they are more prone to make errors. They are more prone to not have the best bedside manner. But Jim, is there other fallout when we don't think about caregiver wellness and patient outcomes?
I mean, I think you've hit on some of the biggest ones, right? We want to make sure that the patients are well cared for and that they are safe, and that a focused and a caregiver with a positive outlook that has a much better shot of taking care of that well. I think that the steps that get missed or forgotten and overlooked, that's what's happening when caregivers get stressed out. And that's the big fear, right? The sort of never events that Joint Commission talks about either usually happen because a caregiver is stressed and misses a step along the way, pulls the wrong medication, develops a workaround, or because they don't feel psychologically safe to speak up when they see somebody else doing that, right? And that's those events that we say, like medication errors and wrong site surgicals, that should never happen. That's I think a big part of the risk that an overstressed caregiver has.
I think you're absolutely right. You know, that point you just made about a comfort level with speaking up about something you see that's happening in your workplace. I mean, these are life and death situations. And then again, culturally, that needs to be encouraged. And you can encourage that only so much as an administrator. But I think what would help that is staff retention, building those teams, building those long relationships with your coworkers, which we're not seeing. We're seeing traveling nurses and, you know, people just kind of light in for a little bit and then they're off to another, you know, area to work or all of those issues. So, you know, when it gets down to, I know for us, when we're successful at putting together a project, it's because we've got a really great team that's working together. So I would think that that is something that needs to be emphasized more. And maybe we can do that in our user group meetings, talk about how you're teaming and how that can impact our design, maybe find ways from our users to help us shape their spaces, to build their teams.
Yeah, I love that you brought up that trust issue. I think that's so important.
Yeah, I think the term relationships is what resonated with me. It's all about building relationships. You don't have that trust until you have that built up relationship in that time where you would feel comfortable bringing things up. And even with me in dealing with administration, it's about the relationships that I have developed with them. And they trust what I say because I have taken the time to build up that relationship. And to your point, Julie, the question should be about the teams that they have. If you're talking to a certain department, and what has the team done to build that team spirit, or whatever you want to call it? You know, what have they done before, and what has succeeded, and what hasn't succeeded, and that would help guide us as architects and designers to react appropriately.
And that team building is a space where our architectural designs can really support it, right? We worked with a big integrated cardiovascular group, many different specialties, and one of their big goals was to create opportunities for what they call curbside consults, right? These informal interactions that happened across different areas of expertise and different types of team members that would just naturally take place through the spaces we create for that. And the way we choose to work with our clients in design space can really foster or unfortunately break down that team building and trust.
Yeah, that's a great point. You know, one of the spaces we all talk about and try to incorporate are quiet workspaces. And I think the most important part of creating those quiet workspaces is not just for the heads down, but that they're flexible so that you can have ancillary staff and physicians and nurses and that mix that you're talking about interact in those accidental meetings and talking about their patient care.
So much of the caregiver process and building teamwork and establishing relationships and increasing trust, right? It's all about this vague idea of communication and how do we enhance communication in the daily activities of the caregivers, you know, between each other, between the patients and the caregivers, between the administration of the hospital and the caregivers. I'm curious from your all's perspective, you know, we're in kind of a technological and data revolution in healthcare right now. How have you seen technology leveraged in the care setting to enhance communication, to help build relationships, to increase staff satisfaction?
The I guess most innovative is the telemedicine piece, in that you can have an expert in the room and anywhere in the country. So I think as we learn more about how to embed that into our patient rooms, and to understand how to integrate primary caregivers with those specialists, I think that is an important function of technology that I see going forward.
That's, I think, been a huge help, especially for rural healthcare, where they may not have physical access to specialists, right? But either their system or system partners can bring specialists to very remote areas and deliver care quickly, but also build care teams that are virtual care teams, but that wouldn't be able to exist without that technology.
Mm-hmm.
Yeah, beyond the telemedicine, I haven't seen technology play as critical a role as it could. I wish that, again, it gets back to that business aspect of it and financials of how you incorporate technology and what you're able to do and not do. But the telemedicine has been one of the biggest impacts that we have seen.
I think one of the other things that we could look at is the tracking of equipment and materials. You know, nurses are the hunter-gatherers of the medical field. And, you know, if they had a way on those little phones to just find what they needed before they, you know, head off in one direction or another, that could be a real satisfier as well.
They are the hunter-gatherers, and especially with equipment, and they took them away where they can find things. I see that all the time. And if I can find where I can find the nail in Home Depot, I should be able to find the equipment I need in the hospital.
I think there's also a tremendous opportunity for technology in the patient care process, right? There's the opportunity to, for example, food on demand, right, in the hospital inpatient room, so that they can pick out whatever they want, order it, have it delivered whenever they want. That's a simple bedside thing. Controls over the environment that the patient has. There's a lot of advancements in technology that way as well that helps the care, the experience the patient has, and it relieves the caregiver of some of the duties when the patient can control it themselves and frees them up to do higher functioning tasks in the department.
That's a really interesting point, Jim. You know, how do you leverage something that we're already doing to a large extent? And you know, tweak it just a little bit to then have the added benefit, the secondary benefit of promoting caregiver wellness here. So I think as we're winding down here, when we think about the design process, we're all designers, we're all healthcare architects, and we talked about this being a top-down decision, right? At the end of the day, there is a financial decision here, and there are some really great reasons why taking care of the people providing care and the healthcare organizations are important. But how can we all use the design process to raise awareness of the benefits of caregiver wellness, and to the hospital administrators who might be looking at this as a black and white bottom line decision?
It starts with education. It starts with conversation. And it has to be a repeated conversation. You know, I started talking about how the pandemic brought everything to the forefront. Well, I think as designers, it's up to us who are working with projects to bring it to the forefront and make sure that it's identified as a critical need. I'm a data person, always looking for the data to substantiate why I have to do a project, why bricks and mortar are now the answer for renovation. So it goes back to Julie had said the same thing. You know, basically, we need to find a way to tie it to a business decision, and the data needs to run that. So if you have the data and you have answers, you can show whether it's retention or whether you are recruiting better or whatever it is, you can show that to your senior administrators. But it's part of educating them to that and showing them the results of that data. And it's about making sure that conversation doesn't stop. If it's mentioned when you start off the process, whether it's a visioning session or whatever it is, keep that going during your planning and your programming. And as you talk to users, you keep that conversation going. And not only educate your senior administrators, but educate those nurse managers and the people that you're designing the space for, that we feel this is an important thing and we want to make sure that it's not forgotten.
You know, I think the use of the data is a great point, but we, as a design profession, design is an iterative process, which means we should have many touch points, and design is storytelling, right? So we should use that data to tell the story to administration through an iterative process, which means we're going to interact with them over and over again, right? We're telling them the same story using that data over and over about the needs of the caregivers, and we engage them into that process at multiple points so they can see for themselves how the data is impacting it, how the caregiver is being impacted by the designs we're doing.
Absolutely agree. I think that this isn't, we're not going to be able to solve this whole issue of caregiver wellness. But I think that we're in the best position to find partners in consultancy that could help us solve some of these issues. And by keeping this in front of our administrators and maybe suggesting some of these partners, we might be able to, as a team, really impact caregiver wellness in the future.
I think you're absolutely right, Julie, that we have an opportunity. While we can't solve it, we can be passionate advocates for it, right? And we can find those other partners, and we can build coalitions that use the data and tell the story that this is important. And that's a vital thing we can do on behalf of caregivers who may not always feel comfortable doing it themselves.
Right. I mean, maybe we look at it the same way that sustainability has embedded itself into healthcare systems, right? So there was the LEAD program that really helped push that along, and now we have other programs that helps us understand, you know, it's not just sustainable, it's resilient. And this is why we do this kind of design, because now facilities folks have seen this is going to save us money, keep us up and running during climate disasters or other you know, impending disasters that we weren't able to deal with before we had resiliency in our buildings. So maybe we look at the lessons from that and try to impose them on this particular issue.
That's a good point. And I think also, as we've talked about, there not being parity in terms of quality of space, resiliency also bleeds over into it even being an equity issue for the staff.
I'm not sure if it's an exact parallel to what you're asking, but I'm definitely seeing resiliency is not just a physical space item, right? Resiliency is about how the staff can respond to the pressures being put on them. And so I'm not sure if I'm seeing resiliency and equity necessarily, but definitely understanding that in a crisis or in a weather event where staff have to stay 2, 3, 4 nights in the hospital, the resiliency of the organization to get through that is not just about the central utility plan, it's really about their staff.
I see that. I mean, you know, there are a few outreaches to understand what would be needed on a unit if staff is staying there for 4 days, more showers, whatever, staff rooms. But I don't see that as a driver for how we design yet for caregiver wellness.
It's a small part of it, but it is not the entire picture. You know, so it's just a sum of parts, basically, that we have to put together, and that's one of those parts.
We'll end with one last question for each of you. If you had, you know, the folks listening at home, right? If you had to leave them with one bit of advice, one word of wisdom, one question to ask, what would it be from your perspective?
For me, one question is what we've been talking about in terms of conversation, education. Don't stop talking about the issue just because it's not on the forefront in social media and news outlets doesn't mean it doesn't happen. And to keep the conversation going and be that advocate. I think as healthcare architects, I think we need to be that advocate.
I think that we need to continue to be curious. We always need to keep asking why about everything when we're with groups that we're trying to design for. That's how we learn.
And building on that, I would say that we really want to make sure that we're engaging the caregivers and understanding what they truly need, right? Letting them be our partners in making spaces that meet their needs and their team's needs.
Wonderful. And we'll end it there. We've covered a lot of ground today on an increasingly important topic. So on behalf of the healthcare community listening at home, thank you very much, Julie, Jim, Kent, for sharing your knowledge, your expertise, your experience, and on how the design process can and does promote caregiver wellness and staff satisfaction. Thank you.